so-called variant histology. And this is also the rate we see in our cohorts, and also is reported in the literature between 20 and 30%. So we see there is an influence on overall survival and also on cancer-specific survival. So reporting these subtypes of urothelial carcinoma definitely has clinical significance. So when we have a look at other tumor systems, for example, here the tumor WHO classification, the current one for the central nervous system tumors, these tumors are mostly defined by histology and also by molecular pathology. And this is here taken from a landmark paper 4 years back from Nature, and they also defined or were able to define the central nervous system tumors by methyloma analysis. So what's the situation in urothelial carcinoma? We have a lot of different transcriptomic studies. I highlighted some, which I think are the most cited ones. Of course, the TCGA studies of muscle invasive bladder cancer, the one and the second one, and also important studies like the MDA study from 2014, and also the UNC classification, the Lund 1 and 2 classification, and then finally the consensus classification of muscle invasive bladder cancer. And there are two systems, the Euromol 1 and Euromol 2 papers for the non-muscle invasive bladder cancers. So of course, there was a big, not really confusion, but there were many publications on these subtypes in muscle invasive bladder cancer, and most of the systems were combined in this consensus classification approach. So they reanalyzed 1,750 transcriptomic data sets from 18 cohorts of muscle invasive bladder cancer and defined 6 classes. So these data sets were taken from the Baylor College system, UNC, MDA, TCGA, Sid Curie, and also from the Lund classification. This is a very famous illustration of the results from this paper, which was published in European Urology 2 years ago, also was available sometime before in bioarchives. And as I want to talk about histology and the way of combination with molecular pathology, I will focus on this part here. So we see these 6 classes, which in most cases are basal squamous, 35%, or luminal papillary in 24%, stroma rich in 15%, luminal unstable 15%, and the luminal non-specified in 8%, and the rare cases of neuroendocrine-like carcinomas. So when we go to histology, these tumors here in the luminal papillary type, they are enriched in papillary morphology, and I will go into more detail later on. The luminal non-specified type is enriched in micropapillary variant or subtype, and of course the basal squamous subtype in squamous differentiation, and the neuroendocrine-like type in neuroendocrine differentiation on the histological level. So these are the results. I will go into more detail now following this slide. So when we think of basal squamous tumors, there is a strong correlation between histology and molecular subtype, but it's not 100%. So from the basal squamous tumors, 79% of the tumors with squamous differentiation are in this molecular subtype of basal squamous tumors, but not every tumor of the basal squamous subtype has squamous differentiation in histology. These are just 42%. So if you see a tumor with squamous differentiation, so with keratinization or with intercellular bridges, you can be pretty sure that this is a tumor which has a molecular subtype of basal squamous, but you cannot be sure that a basal squamous tumor in the molecular subtypes really displays keratinization or intercellular bridges on the histological level. The neuroendocrine-like tumors, that is a different story because they have a very strong association between histology and also molecular subtype, which is between 70 to 80%. The other tumors, the luminal papillary ones, they are enriched in papillary histology, but again, you cannot be sure that a tumor that displays papillary morphology is in this group, because you can also find it in other groups. And the same is true for the luminal non-specified tumors. They are enriched in micropapillary morphology, but and the presence of CIS, but you can also see it in other types. So there is not a 100% correlation. So the question now is, we saw these great papers and great advances in the understanding of the molecular subtypes of urothelial carcinoma. But when it comes down to factors for patient care, are they really of clinical relevance? So are they prognostic? To see that if you see the data from the consensus classification, clearly they are prognostic. They have an influence on overall survival, which is highly statistically significant. But there is also evidence in the literature in this paper here from Kohlberg and colleagues. They did not find molecular subtypes from the Lund or consensus classification to be associated with molecular subtypes. Another question is, are these molecular subtyping systems in bladder cancer predictive for therapy success? So if you see what has happened over the last decades in bladder cancer therapy, over 20 to 30 years, platinum-based chemotherapy has been the backbone of therapy. And just in the last 6 years, we saw an explosion of therapeutic possibilities also in advanced bladder cancer. Of course, we all know this immunotherapy in some cases also connected with companion diagnostic testing for PD-L1, and also in recent days, NTRK inhibitors. Of course, we also all know this. There are very, very few TRK fusions in bladder cancer, but it's a tumor agnostic tumor drug. So we can also use this in bladder cancer. We saw erdafitinib FDA approval in 2019 for FGFR3 fusion positive or mutated tumors from the FDA, and also some other drugs like zacituzumab deruxtecan and enfortumab vedotin to be approved, but without any companion diagnostic testing. So the question is, why aren't molecular subtypes listed here as a companion diagnostic? Are they really predictive of therapy success? When it comes to immunotherapy, these are just examples from the atezolizumab studies from the IMvigor 210 cohorts. They analyzed the TCGA1 system, and the cluster 2 was associated with therapy success. And this is a very nice paper published 3 years ago in European Urology, and they showed that on a single case specified system, the neuronal subtype from the second TCGA study, these patients really benefited most from atezolizumab therapy, which is of course very good. So when it comes to chemotherapy, the situation is a little bit more difficult, because we have this seminal paper from Seiler and colleagues for neoadjuvant chemotherapy, and they found that the basal subtypes profited most from neoadjuvant platinum-containing chemotherapy. But recent papers, for example, from Tava and colleagues, they did not found, or they cannot really find this success, but they saw NAC success for in non-basal subtypes. So the current situation we have here is a histology-based classification system in urothelial carcinoma. We have still different molecular subtyping systems, and these systems have some clinical relevance, and there is some overlap between the molecular and the histological subtypes. So the question is, why do these molecular subtypes have not found the combination with histological subtypes and have not been introduced into clinical pathological routine? I think the answer might be that we still have a lot of non-standardization in these systems, despite the consensus classification. and there are strong analytical differences between these systems. And I think the most important point is that these systems are complex, labor intensive, and very expensive, and cannot be performed in every lab, and sometimes also not on a single case basis, but just in bulk analysis, and mostly not FFPE tissue is used. So this also might be a problem in non-academic centers. So the question is, might there be some technologies that are simpler than these transcriptomic studies to bring this important data from the molecular subtyping systems to the clinical pathological routine? Some groups are working on this topic. We are working on this as well. So this is a paper from Dr. Lopez Beltran and Dr. Cheng. They used a nanostring-based expression analysis approach. This is something we also perform right now, and we recently were able to publish a study where we used a simplified system based on a PCR system with 68 targets. So I will go into a little bit more detail here. So we reduced the TCGA2 data set to a 68 gene set and used this RT-qPCA PCR-based approach and validated it on different data sets which are publicly available and an own cohort. The overlap was between 64 and 79%, and we had a 96% analytical success rate. So this is a kind of simpler system, of course, and we try to make it even simpler. And this is a follow-up study which hasn't really been studied, published yet. So we also choose the nanostring-based approach on FFPE basis and analyze chemotherapy versus non-chemotherapy cohorts. And the overlap with other systems was between 73 and 82%. So the question is now, these systems are simpler than this high throughput transcriptomic approaches, but of course they're still labor intensive and not as cheap or easy to use in our hands as, for example, immunohistochemistry, which we all use for decades now and we're very much used to. So many authors also thought about immunohistochemistry being a surrogate marker for these molecular subtypes. One very important study is from the Texas group from Houston. They used two IHC markers, GATA3 and CK56, to reproduce the basal and luminal subtypes and had an analytical success of 80%. So these are two markers, but other approaches used, for example, 4 markers. In this study from Spain, this from the Erlang group, they used 6 markers, and the subtyping approach from Gottfried Sjödahl, he used 13 IHC markers in this protocol, but in the original publication from the Lund 2 classification, they used 28 IHC markers. So there's a very big difference. So the challenges from my point of view, we're faced with immunohistochemistry in molecular subtyping of bladder cancers is we have to agree on which antibodies do we have to use. It seems to be simple if we just want to discriminate luminal versus basal subtypes, but this might not be enough. So we also have to be aware of which classification system we want to reproduce. How many antibodies do we use? Which assays, platforms, and protocols are important? And I think, which is also very important, which threshold. So do we have a 10% cutoff maybe for CK56, or is it even higher? Which type of tissue do we use? Is TURBT tissue okay, or do we really need the cystectomy tissue? So I think we have to have more data research, and we have to find a consensus from this data as well. So we also did a little bit research on this. This is also from a paper which hasn't been studied, just a few parts. So we try to reproduce the system from Guo and colleagues with 2 markers, GATA3 and CK56. You can see that CK56 is what we know nicely able to reproduce the squamous subtype. GATA3 is positive, especially in the NOS type, but there were also double negative cases, so cases without GATA3 or CK5-6 positivity, and they had a very bad overall survival. We also did some sequencing in these tumors, so we saw that the different systems were mainly overlapping. But in this picture, I want to come to the point, which I think is very important, that there is a bit of heterogeneity also in our cohort, because we analyzed the histology at the point of the TMA, where we did our immunohistochemistry, and on the whole slide of the tumor, which we took out the tissue. So in some cases, there was also variant histology or subtypes of urothelial carcinoma in the whole tissue. And I think this is a very big issue. We have another layer of complexity here. This is heterogeneity, which is very common in urothelial carcinoma. On the one hand, we have the spatial heterogeneity. So we all know these cases. This is taken from one case, a recent case from the diagnostic routine. And you see in this part here, there's this more lymphoepithelial-like carcinoma. In other parts, you see a more NOS, so the typical urothelial carcinoma type histology. And in other parts, there is a typical squamous subtype histology. So this spatial heterogeneity is not just on the histological level, but can also be reproduced on the molecular subtype level. And this is a study from Warwick and colleagues. They reproduced the molecular subtypes by using IHC, using the Lund classification system, and also recorded the different variant histologies or subtypes of urothelial carcinoma. And they found that about 40% of cases exhibited molecular heterogeneity, and this was most present in the squamous basal group. This is another example for this spatial heterogeneity. This is a study from Thompson and colleagues. They analyzed 4 cases with urothelial carcinoma. 2 of them had also lymph node metastases, which they also analyzed, and they did some kind of mapping study. They used whole exome sequencing and also deep targeted DNA sequencing of specific regions, and also recorded RNA molecular subtypes with luminal and basal differentiation. They found that driver mutations are mostly shared, but some are private, and that some of the mutations can also be found in low frequency within the normal urothelium, but this is not the case I want to touch upon here. What they also described was heterogeneity in the molecular subtypes. To quote, our data could indicate the presence of cell plasticity rather than intrinsic inherited subtypes. I think this is a very important sentence, and this is also like the substrate of what we are working on here at the moment. There is not only spatial heterogeneity, but also temporal heterogeneity. So this is a study also from Seiler and colleagues. This is the second one, so not the first one dealing with a neoadjuvant chemotherapy, but the second one. And in this study, they had matched pre and post neoadjuvant chemotherapy samples. And in residual disease, they often found different subtypes than in the primary tumor. And the question now is this real tumor heterogeneity, or is this a selection of cisplatin-resistant clones? But you see this temporal heterogeneity also in other studies. For example, from this paper, Heide and colleagues from the Aachen group, they showed that there is a clonal evolution in invasive disease. So to come to a conclusion, are we really moving towards a unifying pathologic and molecular classification? Another important sentence from Skjødal and colleagues from the Lund 2 paper is, to quote, a combination of molecular pathology, which is tumor cell phenotype, and global mRNA profiling in the context is required for adequate subtype classification of muscle invasive bladder cancer. So I think this is also a very important sentence. This takes together or combines the bulk mRNA profiling system and also our histology-based, tumor cell-based view, which we already have had since the beginning of the modern pathology age. So this means genotype is not phenotype. We all know that, but we have to really think of this. RNA is not protein, and bulk RNA analysis do not represent the spatial differentiation of cell types within this tumor tissue. So to answer the question, are we there yet? Not yet. And will it happen? In my personal view, it will happen to some extent. I think histopathology will continue to be the gold standard. And from my point of view, what I think needs to be done is we have to do more research to compile data on the predictive value of the molecular subtypes, so we can really decide on which subtype is predictive for which situation. We have to perform more research on the spatial and temporal heterogeneity of urothelial carcinoma, and we have to simplify the approaches in molecular subtyping. So that means the technology, the effort, the price, and finally, we have to find consensus about all these technology and assays, and include this standardized approach in prospective clinical trials. I think only with this system or something alike, we will be able to bring all this great knowledge which we gathered from the molecular subtyping studies really for patient care. That was my last slide, and with this, I'm open for discussion. Thank you for your attention.
Thank you so much, Dr. Rice, for the excellent presentation. We have a time for a couple of questions, and I'll lead off with one that was already in the chat. We know from a histomorphologic perspective that urothelial carcinoma are highly heterogeneous tumors, and you've just shown us some elements of molecular heterogeneity. From your perspective, the center that you're at, or what you know from the literature and other colleagues, in terms of the management of some of these mixed molecular subtypes, in terms of prognosis, treatment selection, what's the current thought as this data emerges?
Yeah, that's a very important question. I think at the moment in the regular patient care, we do not perform these molecular subtyping approaches. But if we do have cases with variant histology, strong variant histology, for example, we all know the data from MDA, like micropapillary disease, or also plasmacytoid carcinoma. And if I'm part of the tumor board, we talk about this urothelial carcinoma subtypes. If it's a decision between a more aggressive or a more conservative treatment, we go for more aggressive treatment in those cases. And I think in the future, molecular subtyping will help also in this decision making. And that's where we want to head, because we all gathered this information and we all did this research, and we try to bring it to the bench side.
Excellent. So a follow-up question. So outside of the realm of just research, are you currently using IHC routinely in an attempt to give a molecular classification? Actually,
yes. So we 3 years back now, okay, at the last national meeting of the German Pathology GU group, we not really recommended, but we thought on an approach to do some surrogate marker molecular subtyping system, and we decided on 6 markers. And I'm doing this at the moment, but we'll see what the data really tells us after completion of the study. Because what I really see, and which is difficult, and what I also heard from other colleagues, it's the point of heterogeneity. In some parts, for example, in TRBT tissue, you have areas with GATA3 positivity and then FOXA1 positivity, but also CK5-6 positivity. But I think we have to have more research on that, because that's the question of thresholds.
Excellent. So in the last moment, there's a number of people in the chat who are interested. If you could just name the 6 markers for us that you are using.
Yes, that's FOXA1, GATA3, CK20, CK56, CK14, and P63. But I can also maybe mail the paper, or if somebody is interested, I can also give more information on that.
Excellent. Thank you so much as we hit the 1 o'clock hour for keeping us timely as promised. Now we're going to pause for 1 minute, after which Dr. Ming Zhao, our president, will take us forward into the annual general meeting. Again, thanks, Dr. Rice, and happy to see you in this form of virtual person, even though we couldn't greet you in LA. Dr. Zhao, we're just going to give the 1 minute as a number of people in addition are joining at the moment. So we want to make sure to admit everyone for the meeting.
Thank you very much.
Thank you, Dr. Rees. Let me see if I can share the screen.